All right, let's dive right in. Today, we're tackling a beast of a topic, one that is absolutely essential for your exams and your practice: anti-tubercular drugs. My goal here is to cut through all the noise and give you a rock-solid framework to understand everything from the basic classifications all the way to handling some pretty serious side effects. Let's get to it.
So, here's how we're going to break this down. First, we'll get a lay of the land, what's in our arsenal. Then we'll do a deep dive into the pharmacology of our workhorse, first-line drugs, and the exciting newer agents. And finally, we'll spend some serious time on two topics that you will be tested on, guaranteed: managing liver toxicity and figuring out rifampicint's weird and wonderful immune reactions.
You know, the first rule of fighting TB is simple, but it's absolute. You never, ever use just one drug. If you do, the bacteria will laugh at you and become resistant. Combination therapy is our only defense. But to build the right combination, especially when you're up against the really tough drug-resistant strains, you have to know how your weapons are organized.
And that leads us to the big question, right? When you're staring down a case of multi-drug-resistant TB, how do you even begin to think about which drugs to use? How do we group them? This isn't just some academic thought exercise. This is the core strategy for building a regimen that actually works.
And here is the answer. This table shows the WHO's brilliant strategy. It's a total paradigm shift. Think of it as building a team of superheroes. You always start with your A team. These are your three most powerful agents: a fluoroquinolone, bedaquiline, and linezolid. You need all of them if you can. Then you look to Group B to back them up, adding one or both of those drugs. And only if you still don't have a strong enough regimen, at least 4 drugs that you know will work, only then do you dip into Group C to round things out. This ABC hierarchy, this is the modern blueprint for beating MDR-TB.
Okay, so let's shift focus to the absolute bedrock of TB treatment, our 4 first-line agents. For any regular, drug-sensitive TB, these are your go-to guys: isoniazid, rifampicin, pyrazinamide, and ethambutol. They form the backbone of therapy around the entire globe. So let's really get to know them one by one.
First up, isoniazid, or as we call it, H. It's a prodrug, which is a clever way of saying it's inactive when you take it. The TB bacterium itself has to activate it using an enzyme called CatG. Once it's switched on, it wreaks havoc by blocking mycolic acid synthesis. That's the waxy armor that protects the bacteria. Now for the really high-yield clinical stuff, our bodies get rid of isoniazid through acetylation, and our genes make us either fast or slow acetylators. If you're a slow acetylator, the drug hangs around for longer, and that puts you at a higher risk for a key side effect: peripheral neuropathy. That's precisely why we always give vitamin B6 or pyridoxine along with it. It's non-negotiable. It protects the nerves.
Next up is rifampicin, our master sterilizer. This one is a powerhouse. It works by shutting down the bacteria's ability to make proteins. It binds to its RNA polymerase and just stops transcription cold. But here is the single most important thing you cannot forget about rifampicin. It is a massive inducer of the cytochrome P450 enzyme system in the liver. It basically puts your liver's metabolism into overdrive, which chews up dozens of other drugs, like warfarin, oral contraceptives, and even critical HIV meds, way faster than normal. You have to be on top of these interactions. And of course, it's the drug that famously turns your urine, sweat, and even your tears a harmless orange-red color. Now for pyrazinamide, or Z. This one's a specialist. It goes after bacteria hiding where other drugs can't get to. It's another prodrug, but here's the cool part. Its active form only works in a highly acidic environment, which is exactly what you find inside our macrophages. And that's where the semi-dormant, stubborn TB bugs love to hide out. So pyrazinamide is crucial for sterilizing those hiding populations. But, and this is a big but, it comes with a major downside. Of the 4 main drugs, pyrazinamide is the most hepatotoxic. It can also cause hyperuricemia because it messes with uric acid excretion, so you have to be really careful with patients who have a history of gout.
And finally, we have ethambutol. Honestly, its main job isn't so much about killing bacteria. It's mostly bacteriostatic, meaning it stops them from multiplying. Its real purpose is to prevent the emergence of resistance to the other more powerful drugs in the cocktail. It does this by messing up another part of the cell wall synthesis pathway. Now, the one side effect you must burn into your brain for ethambutol is dose-dependent retrobulbar neuritis. That's a fancy term for inflammation of the optic nerve. It can mess with vision and, classically, with red-green color discrimination. So the take-home point is crystal clear. Any patient starting ethambutol needs a baseline eye exam and regular vision checks.
Okay, let's change gears. We're moving into a topic that has totally changed the game for TB treatment, and, no surprise, is a favorite for those long-form 10-mark exam questions.
This is all about the newer drugs for resistant TB. Think of this next part as your pre-written essay, covering the agents that are giving us a real fighting chance against MDR and even XDR TB.
And here they are, the game changers. Bedaquiline has a totally novel mechanism. It shuts down the bacteria's energy supply by blocking its ATP synthase. Delamanid and pretomanid are from a class called nitroimidazoles that block michael acid synthesis. But look at that last column, the key adverse effect. For both bedaquiline and delamanid, the big one, the one you have to worry about, is QTc interval prolongation. This can lead to potentially fatal cardiac arrhythmias. So the rule is simple. If your patient is on bedaquiline or delamanid, you are doing regular ECGs to monitor that QTc interval. It is absolutely mandatory.
So, while these new drugs bring new worries like QTc prolongation, let's circle back to what is, without a doubt, the single most important and most frequently tested complication of our first-line drugs, drug-induced liver injury, or DILI. I'm not kidding. If you look at past exam papers, this topic comes up again and again. You just have to master this.
First things first, the definition. You need to know this verbatim. We call it ATT-induced hepatotoxicity if a patient's liver enzymes, their ALT or AST, go up more than 3 times the upper limit of normal, and they have symptoms like nausea or jaundice, or if their enzymes go up more than 5 times the upper limit, even if they feel perfectly fine. Just remember the numbers, 3 with symptoms, 5 without. And who are the usual suspects? Remember the order of toxicity. Pyrazinamide is the worst offender, then isoniazid, then rifampicin.
So why does this happen? Well, think of it like a perfect storm in the liver. Isoniazid gets broken down into a metabolite that's potentially a little bit nasty. Normally, your liver could handle it, but then along comes rifampicin, which, as we know, puts the liver into metabolic overdrive. This revved-up system takes that isoniazid metabolite and converts it into a truly toxic compound that directly kills liver cells. It's a classic case of one drug making another one far more dangerous, and it's why this combination is so effective, but also so risky.
Okay, so understanding the problem is one thing. Now let's talk about the solution. This is crucial. When your patient develops hepatotoxicity, you can't panic. You need a clear, stepwise plan to manage the situation and safely get them back on treatment. Now, I know this flowchart looks a little intimidating, but the logic behind it is actually very straightforward. Let's break it down into 3 simple phases. Phase 1. The moment you make the diagnosis of hepatotoxicity, you hit the brakes. You stop the 3 main hepatotoxic drugs, rifampicin, isoniazid, and pyrazinamide. Phase 2. You wait. You monitor their liver function tests every week until they've come down to less than 2 times the upper limit of normal. And Phase 3. Once it's safe, and only then, you begin the re-challenge. And this re-challenge protocol is incredibly specific. The whole point is to figure out which single drug was the culprit, so you reintroduce them one at a time, and the order is mission critical. You start with the most important and least hepatotoxic drug first, rifampicin. Give it for 3 days. If the LFTs stay stable, you add the next one, isoniazid. Another 3 days, still stable? Then you add the last and most hepatotoxic one, pyrazinamide. If at any point during this process the liver enzymes shoot back up, you found your offender. It's the last drug you added, and you stop that one permanently. This specific HRZE order is a classic exam question. Okay, for our last major topic, we're going to look at something a little different, a really fascinating problem. Rifampicin's immunological reactions. Now, this isn't about the drug directly poisoning an organ like the liver. This is about the patient's own immune system getting confused and launching an attack because of the drug. The absolute key concept to understand here is the dosing schedule. These immune reactions almost never happen when a patient takes rifamycin every single day. They happen when it's given intermittently, say 3 times a week, or if a patient stops and then restarts treatment. Why? Because those gaps give the immune system a chance to see the drug, think it's foreign, and build up anti-rifamycin antibodies. In contrast, taking it daily keeps the immune system constantly exposed, which seems to create a state of tolerance. So the dosing schedule is everything. So, what do these reactions look like? Well, the most common one is a pretty straightforward flu-like syndrome with fever, chills, and muscle aches. Often, you can manage that just by switching the patient to a daily dose. But there are much scarier, life-threatening reactions. An immune attack on platelets causing thrombocytopenia, an attack on red blood cells causing hemolytic anemia, or an attack on the kidneys causing acute renal failure.
And here is the take-home message, the critical point. If a patient has any of these severe reactions, it is an absolute permanent contraindication to ever giving them rifampicin again. You do not re-challenge, period.
Which really brings us full circle, doesn't it? We have this amazing arsenal of drugs, old and new, to fight what is still a devastating global disease. But every single one of them comes with a risk. As we move forward, with new challenges like drug resistance, the fundamental tension in TB therapy is always going to be this: how do we treat this infection as aggressively as possible, while at the same time meticulously protecting our patients from harm? That's the question that will continue to define our field. Thanks for joining me for this explainer.